is heart failure and the great salt paradox. And let me get this going here. So the outline is as follows. So basically I wanted to talk about what we know about hypertonic saline in heart failure. The problem I have with the term of hyperdiuresis, where if you look in the literature, talk to people who do this a lot, that's generally how it's referred to. I'm going to propose a hypothesis for why this might be effective, and then we'll go through a few things in the pipeline that are looking at this. But as we often do, I'm going to start with a case. So this is somebody I saw probably 7-8 months ago now. It's a 60-year-old man with non-ischemic cardiomyopathy. This was due to anthracycline exposure for a prior diffuse large B-cell lymphoma. He had a heart transplant in 2018, was initially admitted due to concern for rejection, developed cardiogenic shock, had a balloon pump, which had been subsequently removed. When I saw him, he was on a dobutamine drip. He has a history of chronic kidney disease with a creatinine of 1.5. That's secondary to a solitary functional kidney because of obstruction from his prior lymphoma. He had been on a Bumex drip for the duration of his admission. He was down 7 kilos from his admit weight, but at the time that I saw him, he was urinating 3 liters a day with a central venous pressure of 15. His urine microscopy was bland, and the consult was for acute kidney injury. You can see his electrolytes here. Probably the most marked changes are the BUN of 183 and the creatinine of 4. You guys obviously know what the intervention was based on the title of the talk. Consider what you might do in that situation. I'll go through his course at the end. So to really go into the studies looking at hypertonic saline, probably the best and in fact the earliest main trials come out of Italy. It's actually a single center in Palermo. This was a smaller kind of almost a proof of concept study in 2000. It was, again, single center out of Palermo. 60 patients with refractory heart failure were randomized to either IV Lasix at a dose of 500 milligrams to a gram plus hypertonic saline at a dose of 150 cc's of either anywhere from 1.4 to 4.6%. And that determination was made based on a patient's serum sodium twice a day versus Lasix alone. And I'm showing you the results here, highlighting a couple things. You can see that, so you're seeing Lasix alone on the left, Lasix with hypertonic saline on the right, and body weight changed actually pretty equally between the two groups. The patients who got hypertonic saline did urinate about 500 cc's more per day. And if you look at their creatinine, patients who got Lasix alone, their creatinine rose at the time of discharge from an average of 1.6 to 1.9 versus creatinine that improved from 1.6 to 1.4 in patients who are given adjuvant or adjunctive hypertonic saline. So the same group then published this study in 2011. This is the largest study we have. It was the SMAC heart failure trial. It was over 1,900 patients. They used a similar protocol, except they went one step further. And so the patients who got hypertonic saline and furosemide in the hospital were then put on and discharged on a, quote, moderate sodium diet. They defined that as 2.8 grams or less of sodium a day. And then the patients who got Lasix alone were put on a low sodium diet, and that was defined as 1.8 grams of sodium a day. And the inclusion criteria for this trial was adult patients, obviously with congestive heart failure. They had to be unresponsive to high doses of Lasix, in addition to aldactone, ACE inhibitors, and nitrates for at minimum 4 weeks. Their EF had to be less than 40%, and their serum creatinine and BUN had to be less than 2.5 and 60 respectively at the time of randomization. And so a similar table to the first trial. Now you're seeing patients who got Lasix with hypertonic saline on the left, Lasix alone on the right. In this study, they did show a more significant decline in body weight in patients who got hypertonic saline, similar 500 cc's more of urine output a day. And again, a similar pattern in improvement in kidney function, at least based on creatinine criteria in patients who got hypertonic saline, with worsening in the patients who got Lasix alone. Um, and the other things they looked at were more kind of long-term outcomes. They did show that hospitalization time was decreased in patients that got hypertonic saline by an average of 2 days, suggesting they achieved decongestion faster. And then with a long follow-up time, about 5 years, they showed a pretty impressive reduction in mortality on patients who initially got hypertonic saline and then were put on the 120 millimole per day sodium diet. This was confirmed or at least verified with 24-hour urine collections on a yearly basis after discharge. I didn't show that table, but it actually did correspond pretty well. In the patients who were put on the 120 millimole diet, their 24-hour sodium excretion was about 115. Patients who got the 80 millimole diet, their sodium excretion was about 75 millimoles per day. So pretty impressive Kaplan-Meier curve showing the same thing. So the top curve on the top here. So the patients who got a higher dietary salt intake had a significantly reduced risk of mortality, and the curve separated after 30 seconds or so of randomization. And so, in interest of time, there are other studies. There's some out of Brazil, Japan that essentially show the same results. But since we're in this country, I wanted to at least show the one study we have out of the US. So this is out of Yale. It's not a randomized trial. It's just a single center retrospective review, essentially looking at their own experience giving hypertonic saline. So they looked at 58 administration episodes over 40 patients. So essentially, if a patient got hypertonic saline for a second or third time, as long as it was 1 week apart, it was considered a unique episode between 2013 and 2017. The protocol they used was 150 cc's of 3% saline as a bolus over 30 minutes in conjunction with high dose loop diuretics. And so again, no control group here, but they did show a substantial increase in urine output after administration of hypertonic saline. Weight came down significantly, looking 3 days pre, 3 days post hypertonic saline administration. And again, similar to the Italian study, they showed an improvement in creatinine. The other thing they looked at here was diuretic efficiency. In this study, they defined this as milliliters of urine output per doubling of the diuretic dose. And with that criteria, they showed a significant improvement in diuretic efficiency post hypertonic saline administration. And when we first started utilizing this here at the U, there were concerns about safety, understandably from the cardiologist. None of the studies have shown really any significant harm. Specifically, this study looked at worsening in oxygen utilization, and there was none pre and post hypertonic saline. And you can see the kind of the display of changes in serum sodium. I can tell you there's really nothing clinically concerning based on the levels of sodium that patients were starting with. And what's important to point out is this was actually a pretty sick population, at least in this US-based trial. There was 64% of the patients were either inotrope or vasopressor dependent. There was a 47% 30-day rate of death, hospice, or readmission. About a quarter of the patients had an LVAD, and 65% of the patients had an EF less than 40. So overall, a sick population of patients. So this all sounds great, right? You give hypertonic saline, people pee, they leave the hospital earlier, they live longer, all sounds great. The issue I have with it, again, if you look at the studies, we talk to people who are using this, it's termed as hyperdiuresis. There's some mechanism that's causing patients to urinate more, get decongested faster, and hence do better. The issue I have with that is here. So unfortunately, not all the studies report this. The only studies that actually report this are the initial Italian studies. So they actually did look at 24-hour urine sodium excretion and before and after hypertonic saline administration. And what I'm showing you here, so again, this is that initial smaller study with 60 patients. Patients who were given Lasix alone, their 24-hour sodium excretion was 129 milliequivalents. If you got hypertonic saline, it was 198 milliequivalents. In the larger SMAC heart failure trial, so now Lasix with hypertonic saline on the left, 119 milliequivalent urinary sodium excretion. Lasix alone was 76. And so here's the math. That's a difference of 69 and 43 milliequivalents respectively. And I don't unfortunately have an appendix of how many patients got which concentration of saline, but if you would just take kind of a general, look at this, 150 cc's of 3% saline has 77 milliequivalents of sodium. 1.4% saline, that's 41 milliequivalents of sodium. So what it looks like to me is at best, these patients are just peeing out the sodium that we're infusing in. And at worst, they might actually be retaining additional sodium. So that doesn't make sense. In fact, when we think about diuresing folks with heart failure, what we really care about is natriuresis, right? So I know here we follow urine sodium levels to make sure that we're achieving adequate natriuresis. We actually added that to the diuretic protocol. And so what we might be seeing is that patients are really just getting dehydrated. They're getting this extra solute load, they're excreting it, they get an obligate aquaresis, and they're just getting dehydrated. That's the urine output and the weight decrease. I don't know that for sure, but that's based on this. That doesn't explain the mortality benefit if we believe that that's real. And so I presented this a couple of years ago at professors' rounds at the U, and I could not for the life of me think about what the mechanism might be until I decided, well, maybe I'm thinking about the wrong ion. Maybe it's not the sodium, because that doesn't make sense. Maybe it's a chloride, and we tend to ignore chloride, but maybe that's what's important. So I'm going to warn you that this is kind of a data-free area, and what I'm going to be proposing now is more for hypothesis generation, trying to create some biologic plausibility for this. And so for the next part of the talk, I want to talk about the association that hypochloremia has with prognosis, neurohumoral activation, and diuretic resistance, specifically in patients with heart failure. So when I was a med student, resident, fellow, I always understood that hyponatremia in heart failure patients was associated with bad outcomes, with higher mortality as a sign of disease severity. There's a lot of emerging and kind of recent data that suggests that it's actually hypochloremia that has the highest association. So this was a study out of Yale in 2016. They were looking at outpatients with heart failure. So this is looking at mortality at baseline, 3 months and 12 months. And in fact, hypochloremia had the strongest association with increased mortality risk. And when you actually adjusted for chloride, any effect that sodium had was completely mitigated if you corrected for chloride. And then in inpatient, so this was in 2015, looking at survival stratified by admission hypochloremia and hyponatremia. And in the bottom 2 lines here, you can see that hypochloremia was associated with decreased survival irregardless of sodium level. And in the orange bar up here, hyponatremia actually had no impact on survival if chloride levels were in fact normal. And the issue always is, right, we don't know, is hypochloremia just a marker of disease severity or actually a therapeutic target? Similar to sodium, right? We can use tolvaptan, reliably raise sodium levels, but don't improve any hard outcomes. And either that's because sodium is just a marker of disease severity, or it's not actually associated with mortality like we thought. I think with chloride, there is at least biologic plausibility. And so the next part is neurohumoral activation. And when I gave this talk to the cardiologist, I had to spend more time here. I think most people in the audience probably know this, but chloride obviously plays a key role in kidney physiology. And specifically, what I'm looking at is renin release from the macula densa. So this was a study in rats where they measured plasma renin activity before and after the infusion of various sodium salts. And what you can see down here is that it was only when they got chloride that they had suppression of plasma renin activity. I didn't know this before this talk, but I guess the kidney can use bromide instead of chloride, and it serves the same purpose. And they similarly saw an improvement in renin activity, or at least a suppression of renin activity. Lysine chloride had the same effect versus lysine glutamate, so without giving chloride did not impact renin activity. And then similarly from 1983, the study again in rats looking at plasma renin activity with an oral intake of various salts. And again, with the asterisks here, the only significant suppression of renin was if they got chloride or bromide. And then the same thing we saw analogous to the prior study infusion, IV infusion of various sodium salts, it was only when they got chloride that they suppressed renin. And the only study I could find in humans was this. It was a very small study. It was 16 men aged between 20 and 30. They were fed a 10 milliequivalent sodium chloride diet for 5 days. And then they underwent infusion of either sodium chloride or sodium bicarbonate. And sodium chloride did suppress renin activity. Sodium bicarbonate did not have any effect. So that shows that yes, chloride can suppress renin activity, but can it stimulate renin activity? And it turns out it most likely can. So this was a kind of an interesting study, again in rats. They essentially measured plasma renin after 105 minutes of peritoneal dialysis against either a sodium bicarb or sodium nitrate bath. The control was sodium chloride, so they're essentially selectively creating chloride depletion without impacting sodium. And you can see that chloride depletion here did raise renin activity. And that's important because we know the role of neurohormone activation in heart failure it plays kind of a vital role. This is just out of UpToDate. This is stable outpatients with heart failure, and they show that you have higher levels of norepi, renin, ADH. That kind of process becomes maladaptive, and that's why we use RAS inhibitors, beta blockers, etc. So what about diuretic resistance? So this is, so on the left here, you have the kind of the nice review by Ellison in the New England Journal in 2017, showing that with chronic exposure to loop diuretics, you do get hypertrophy of your distal tubules, upregulation of NCC channels, ENaC channels, pendrin, and the intercalated cells. And then on the right, you're looking at mRNA staining of NCC channels. Control versus exposure to loop diuretics, and you have an upregulation of NCC channels. And kind of along with that, there was a study again out of Yale. This is, they have an interesting setup. They have a transitional care unit at Yale where patients with heart failure can come in as outpatients. They spend 4 to 8 hours where they're assessed by a physician and they're given either IV or oral diuretics based on their volume status to try to keep them out of the hospital. And what they looked at was diuretic resistance. And this was calculated as sodium output per doubling of loop diuretic dose. And they again showed that hypochloremia was associated with diuretic resistance, irregardless of sodium levels. Low sodium had no impact, predicated on normal chloride levels. And so to try to understand this further, I wanted to look at, so how are these NCC channels regulated? And there's a family of Wnt kinases, specifically Wnt1 and Wnt4 that control this. And so this is in 2003, looking at oocytes that were injected with NCC plus Wnt4 or NCC plus Wnt4 and Wnt1. And you can see that total NCC channels was the same, regardless of what was injected. But with the immunohistochemistry looking at surface expression, so obviously the control is NCC channels alone. If that was injected with Wnt4 seemed to suppress NCC activity by at least 85%. If Wnt1 was added to that, then it appeared to prevent the inhibition, and you could see, surface expression was similar to the control. And so what it seems like is that Wnt4 provides basal suppression of these NCC channels. Wnt1 can remove that inhibition and essentially activate them. And this is looking at mice that had missense mutations in Wnt4, and you can see that they showed hypertrophy in the distal convoluted tubule and upregulation of NCC channels, similar to what we saw with exposure to loop diuretics. And so my simplistic view of this, and the reason I say that is there's kind of isoforms of these that make it somewhat more complicated, is that Wnt1 stimulates and Wnt4 essentially inhibits NCC activity. So what does this have to do with chloride? Well, it turns out that these Wnt kinases are chloride sensors. And so this was a study in 2019 looking at knock-in mice with chloride insensitive mutant Wnt4, and those mice phenotypically displayed hypertension, hyperkalemia, and hyperactive NCC channels, so essentially Gordon syndrome. And what they then did was they took 2% potassium chloride, infused it, And what you can see here is that there was no change in the total number of NCC channels, but when mice, at least wild type mice, got potassium chloride, the phosphorylated or active NCC channels was significantly reduced, and there was no effect in the knock-in mice with the chloride insensitive WNC4. Also WNC1, so it looks like on WNC1, this is crystallographic studies showing a binding site for chloride directly onto WNC1, and in low chloride conditions, this is not present. WNC1 can autophosphorylate, become active, and hence indirectly activate NCC. And we have some potential evidence of this. So again, this is going back to that Yale study. And when they showed diuretic resistance, what they showed was, so I know it's hard to read, this is patients who had no hypochloremia. These are patients here who did have hypochloremia. There was no significant difference in the amount of diuretic excreted. So it looks like the diuretic is reaching the kidney. There was no difference in the fractional excretion of lithium, so there was no effect on the proximal tubular function, but overall decreased diuretic efficiency. That does suggest this issue is happening in the distal tubule, which would correspond with the physiology. Unfortunately, none of the studies aside from the US study looked at or at least reported serum chloride levels, and in that study, every patient was in fact hypochloremic. And so where do we go with this? What are the clinical implications aside from just hypertonic saline, and what's in the pipeline? So our service, we use a lot of Diamox, and this is not a perfect study by any means. It was only 30 patients. It was a little strange where they had, so these are all heart failure patients that were given Diamox. 12 of the 30 were in this modification group where their sole reason for getting Diamox was hypochloremia. There was also a decongestion group where patients were given Diamox essentially as combination therapy with loop diuretics for better decongestion. And so this is before and after Diamox administration. So you can see the serum chloride here was actually not that low in the entire cohort, 99. Obviously, the patients who were hypochloremic had significantly lower levels. What it did show that you could reliably raise chloride levels in both in the short term and in the long term, looking at up to 60 days. And so showing effectiveness of Diamox for raising chloride levels. This had been looked at in one relatively small study out of Belgium last year. And so this was 34 patients getting, with decompensated heart failure, getting 1 to 2 milligrams of Bumex plus acetazolamide, or just high dose Bumex, which was essentially double their home dose in IV form. The primary outcome was 24-hour urine sodium excretion, and there was no difference in that. Similarly, no clinical difference in signs of congestion at baseline versus 72 hours. But what they did show was an improvement in diuretic efficacy, again defined as natriuresis corrected for loop diuretic dose, shown here in the acetazolamide group. And no significant difference in all-cause mortality or heart failure readmission. So essentially what this showed was, that you can achieve the same kind of markers of decongestion with lower loop diuretic use as long as you get Diamox. That's not really what we're asking. I mean, that's kind of obvious if you give sequential nephron blockade, but maybe an improvement in diuretic efficacy. And there is another study looking at this, the ADVOR trial. This is looking at acetazolamide in heart failure patients. They were supposed to be done with this study next year, but because of COVID, they've had a hard time recruiting. So I think it's going to be slowed. And the last thing, I hesitated to even include this because it's going to kind of deconstruct everything I just talked about. That same Yale study in 2016, they took 10 patients in their transitional care unit that were getting at least 80 milligrams or more of furosemide equivalents, and gave them 115 millimoles per day of lysine chloride for 3 days. They showed that they reliably increased sodium chloride levels with that dose. Unfortunately, and maybe paradoxically, plasma renin activity went up. So that goes against everything I've been talking about. The glass half full way to look at this was, well, serum albumin improved, weight came down significantly, there was an improvement in BNP, and a rise in BUN and creatinine. And so one, again, if I'm trying to convince somebody, was that the intervention worked too well and patients actually got somewhat hypovolemic given all these signs of hemoconcentration. We obviously don't know that. There's another study looking at this. It's not supposed to be done until 2024, giving lysine chloride to patients. And so it's going to be a while till we probably have an answer. So in summary, back to our patient first. So he, as you would predict, we gave him hypertonic saline. Here, looking at the next week's worth of data, his chloride did increase to normal levels. BUN went from near 200 to under 100. Creatinine went from 4 to 2. And we've used this now. I looked yesterday, we've used this in about 9 patients. David may have more, I'm not sure. And we've had a fair amount of success using this. So in summary, hypertonic saline in the correct patient, I do think patient selection is key, may have beneficial effects, including mortality. And the effects may be exerted through chloride because of the biologic things I showed you. We really need further studies, obviously, to know if chloride is a true therapeutic target. The way I think about this is that there's very little harm to doing this, and at least in the studies that I've shown and our own experience, we've been successful in essentially avoiding dialysis, because that would be kind of the next step. And whether that's through improvement in neurohumoral activation, improvement in diuretic efficiency, we don't know that yet. So I will stop there, and I'm happy to take any questions if we have time.
I have a question for you. So really nice talk. I thought, when you give hypertonic saline, I thought you'd pull out water from the cells, and high chloride delivery to the macula densa would restore tubuloglomerular feedback, would cause afferent arterial vasoconstriction via adenosine and lower renin levels. But at the same time, you're giving Lasix, which would also block the Lasix sensitive channels. The macula densa chloride sensor is actually NKCC2, so you're also blocking that. So you're getting null effect, and then the water that you pull out of the cells just goes out in the urine. What do you think about, because you're also blocking the chloride sensor in macula densa when you give furosemide?
Yeah, so that's a question that I don't think we necessarily know. And you're right, all these studies have been done with concomitant loop diuretics, which would have the effect that you're alluding to. I think it's similar to SGLT2 inhibitors, right? I mean, that's supposed to work through tubuloglomerular feedback, but we know that it's effective even in the context of loop diuretics, and they have a very unique kind of diuretic diuresis profile. And so I don't know the answer of why one kind of surpasses the other one in terms of the effect it has there, but it's a good point. But again, all these studies, in the same way we use it, we only use it in conjunction with loop diuretics.
And there's a question from Rags that he sent me. In any of the clinical trials of hypertonic saline with diuretics, has anyone measured change in plasma renin activity?
So not the hypertonic saline trials themselves. So the only ones we have are the small study using lysine chloride. But that would have been nice. But a lot of those studies predate kind of a lot of these, this movement with chloride and heart failure and neurohumoral activation. And so they did not do that.
And then a question from Ian, agree it could be more about more than just sodium. Instead of, or in addition to sodium or chloride, could water actually be the problem that's improved with hypertonic saline?
Well, so I maybe, I mean, I do, think that, again, a lot of the urine output and weight change we're probably seeing is due to, aquaresis or water excretion. I don't know. I think these, future studies that are looking at giving just chloride, may be helpful. I don't know if that's part of the reason why, potassium chloride is effective when we restore chloride levels in patients with heart failure. But I do think what we're seeing with hypertonic saline, at least in the acute setting, is from a water diuresis.
Yeah, and maybe, we're always taught that to disparage water, that it just follows salt and chloride, and it's salt and chloride that are the issue. Maybe water excess is more of a problem than we recognize.
Yeah, I mean, there's two issues here. One is that, and two is this whole concept of a sodium restricted diet, which really means a salt restricted diet in these patients. And that's, you know, that's level C evidence. There's not great evidence to support that. And there's some people looking at, you know, should we be liberalizing salt intake in heart failure patients?
Just a quick comment. I think this is a sort of a fascinating sort of change of the way we look at chloride. We've always sort of looked at it as kind of the forgotten anion. So I suppose two comments. One is the results of the hypertonic saline are amazing to me because of how little is given. You know, it's like a single shot of 45 millimoles of sodium chloride. So it's such a small amount, and yet they're getting these results. And then the second comment is looking at low chloride levels. So if chloride levels are low, there must be another anion taking the place unless the sodium is very low also. So presumably that other anion taking its place is bicarbonate. So is a low chloride level just a marker of a metabolic alkalosis in these patients?
Yeah, and I, you know, I wish that all these studies had reported bicarbonate. Surprisingly, they didn't. That is, to your point, commonly what we see in our patients that we're using this for, that there's a decline in chloride with a concurrent rise in serum bicarbonate levels.